Hi, everyone. Welcome to another Shop Talk. I have Dr. Austin Sheldon here, and we're going to be talking about his paper titled Adverse Events Associated with Manual Therapy of Peripheral Joints, a Scoping Review. And it was published this year in the Journal of Bodywork and Movement Therapies. Austin, it's great to have you on Shop Talk. Do you mind telling us a little bit about yourself, your background,
Sure.
your current role, and your research interest?
Absolutely. So first off, thanks for having me on. I'm excited to talk about the work that Steve Karas and I did. A little bit about myself, been a physical therapist since 2008, graduated from Regis University. I have to shout out to Doctors Flynn and Whitman and Notaboom because they really were the foundation, for pursuing excellence in physical therapy. Out of school, I went up to Cheyenne, Wyoming, worked for 2.5 years in a neurological setting. So, CVA, TBI, post-polio, MS, that sort of thing, all the while taking orthopedic and manual therapy continuing education classes because that really is what my passion was. But after about 2.5 years of that, I moved to Western rural Nebraska, where I worked in a critical access setting, mostly doing hospital-based outpatient, but also working in the emergency department, working with 3 different high schools across various counties of Western rural Nebraska, doing inpatient care, skilled nursing, and post-op care. And it was there that I realized that, I needed to be better than what I was as far as orthopedics go. So I did a residency, the NIOMT Andrews University orthopedic residency, and finished that in 2013. And then moved into fellowship training with NIOMT. Finished my fellowship with them in 2017. Moved to Northern Kentucky for a while, practiced there, then up to Michigan to work in the clinical excellence department for ATI, and finished my doctorate in clinical science at Andrews University last December. Now I am an associate professor at Rasmussen University. It's a 2-year hybrid program. We're admitting our first class starting January next year. And I'm the program director for the NIOMT Messiah University Orthopedic Residency Program. We're also admitting our first cohort next January. We are a candidate program. I've got to say that as a disclaimer. And so, yeah, that's kind of what I'm doing now. Teaching entry level, teaching in residency, and I also am a fellowship instructor for NIOMT.
Wow.
I guess I would say my research interests focus around clinical reasoning, particularly adverse events, as we'll talk about here today, but also vital signs assessment and orthopedic physical therapy practice, which was my dissertation work, social determinants of health and influence on MSK outcomes, and residency training and residency outcomes and the value of residency training.
Super. Wow. Cheyenne, Western Nebraska. I think we can find a place in Alaska for you somewhere.
That might be next.
So tell me something. You published in the Journal of Bodywork and Movement Therapies, and I think you're the first person that has been on that's actually published in that. What was your experience with that journal?
Yeah, so I would preface the answer to that question by saying it was not the original journal that we submitted this article to. Without naming names, we had originally submitted this paper to a different journal, and we were met with some very quick resistance about what our definition of manual therapy was, as well as the physical therapist's scope of practice as it pertains to dry needling. So we had a lot of back and forth with the reviewers with that specific journal, and ultimately decided to pull the article because it just wasn't going well, and we weren't coming to an agreement. So to start, it wasn't a great experience. When we decided to resubmit and find a different journal, we found the Journal of Bodywork and Movement Therapies, and I would say it was a lot more positive. It was a lot more collegial, not negative, and there wasn't the pushback with the reviewers and the editor that there was at the other journal. So they're very responsive to our needs. So we were working on this paper during COVID. Also during a time when I was trying to finish my dissertation. So they were very helpful in even allowing us to take a couple extensions. I was teaching myself SPSS, and I had to take care of some things on the stat side. So they worked very well with us. So I am very pleased with how things went with JBMT.
Awesome. Yeah. We've all had those experiences with some journals, I think, and it's worth noting in the paper that you use the APTA definition for manual therapy. So I think, you didn't like stretch your definition on that. It was a pretty well-grounded one. So I gotta say, one of the things that interested me is you looked at adverse events in the peripheral joints, and there's, you had mentioned there's hardly anything out there. I have never seen anything out there. I've seen heaps of things on the spine. We just had Martha Funabashi on a couple weeks ago. What was the trigger? What prompted you to look at adverse events in the peripheral joints?
Yeah, so I would say there was a couple different triggers for the inspiration on this paper. One being, during the course of residency and fellowship training, and then fellowship instruction, we do pay a lot of attention to the possibility of adverse events with mobilization or particular manipulation to the cervical spine. The IFOM cervical framework, lesser extent thoracic and lumbar spine. So I always kind of wondered, are we just not paying attention to the periphery? They have feelings too. But secondly, being in the clinic and being a clinician that practices manual therapy and watching other clinicians, utilize manual therapy, especially with dry needling, with the advent of myofascial cupping, there'd be times in the clinic as someone who resisted to training in dry needling and then doing it and having some adverse events occur that I could probably attribute to what I did, and also watching some things occur that other therapists did, whether that's dry needling or cupping, and then just realizing there's not a lot of literature out there. We're quickly, adapting these treatment techniques, but I don't think we were giving a lot of thought to, the potential for adverse events, the potential for harm, and there's really nothing out there. So it was just an effort to maybe start the conversation.
Yeah. So I know that there are a lot of definitions of adverse events, and in Martha's talk, we actually had multiple different things that they were called too. And I think you used Carnes's definition in your paper. If I'm correct, do you mind just reminding the listeners what that classification system is?
Sure. So that's one of the things that I would say we struggled with in writing this paper is when you look at the literature, whether you're reading Dr. Carlesso's work or Dr. Carnes' work or Dr. Funabashi's work or anything else, there's different schemas, whether it's classified as not adverse to mild to moderate to severe, if they're basing it off of, descriptive, kind of more descriptive definitions, just a ton of gray areas. The same thing that we struggle with when we talk about, defining our terms and techniques for manual therapy as far as joint mobilization and manipulation. There's just too much out there, and there's no agreed upon definition. There's no agreed upon classification. And so we chose Dr. Carnes's work to use in our table just because we felt like it encompassed more of all the different schema that are out there. So not adverse to severe, duration, whether it's hours to days to weeks to months to years, and then severity. Is it transient, reversible? Is it non-reversible? What are some of the examples of all that? We just felt like that would be able to capture the intent of our scoping review the best way at the time.
Is that the same classification scheme you use at NIOMT, or do you guys use a formal classification system there?
So that's the thing too that I would say in being an instructor for NIOMT, we don't really touch on, outside of the spine, adverse events. Now we might talk about doing your ligamentous stress test before you do a manipulation to the elbow or the talocrural joint or the subtalar joint. But when it comes down to adverse events, at the time, that we did this paper, we didn't use anything, so that's a fair question. It's not used broadly within NIOMT.
Okay. Yeah. And I just know that, I used to do the manual therapy shopping where I would try all the different programs. Now this was some time ago, but no one really discussed adverse events. So I just appreciate the fact that people have classified it and now they're incorporating it into their training. So let me ask, just tell me what you found, just an overview of what you found with respect to adverse events at the periphery.
Sure. So I think we ended up having like 646 articles that met our inclusion criteria. For the most part, at the end of the day, there was 20 articles that fully met our inclusion criteria. And then among those 20 articles, there was 53 documented adverse events. Basically, what we found is that with mobilization manipulation to the periphery, there are hardly any adverse events, and if there are, they're mild. If you look at our table 1, they're mild or transient, they're reversible. It might last a couple days. And then we also kind of stratified it into soft tissue techniques. So talking whether non-invasive soft tissue techniques, massage, soft tissue mobilization, myofascial cupping, and then dry needling and acupuncture. And, we, other than just counting the number of adverse events that were reported, we didn't do any other quantitative analysis. It's a, right, scoping review. But tends to look like with the invasive soft tissue techniques, there's a greater occurrence of adverse events, which kind of makes sense when you're blindly, potentially sticking needles in where you don't know the anatomy variances there. Things may happen. The most common adverse events we found for the soft tissue techniques were pneumothorax, particularly when you're treating the shoulder, the scapula, and aneurysm, so aggressive soft tissue mobilization to the popliteal fossa. There's a few cases of popliteal aneurysm, a few cases of infection, and then even with your cross frictions or your cupping, there was incidences of nerve palsies that you just did not see happening with the joint mobilization or manipulation.
Interesting. Okay, so knowing that, how does that influence how you teach? And knowing that you found less on manipulation mobilization, do you gear your students more toward that particular area, or do you just talk about the risk? I mean, how do you strategize on that?
Sure. So what my teaching style is really, if you're gonna use manual therapy, make sure you're choosing, try to choose the right treatment at the right time for the right patient, and that might differ depending on what you're seeing that patient for. At the end of the day, joint mobilization manipulation, it's a good way to get in there, to do something quickly, to do something safely, to really make those short-term changes happen, that window of opportunity, acting on the neurophysiological system. So then you can quickly get into your, whatever you want to define it as, therapeutic exercise, neuromuscular reeducation, any of the interventions that are shown to produce long-term positive changes. So in that sense, especially for the periphery, if you have a choice, clinicians are really busy these days. I don't think it's a good idea to put needles in someone and walk away and treat another patient. If you have a choice, mobilize, manipulate, get them moving, get them on a very focused exercise program that you observe, that's going to make the long-term changes possible and make the changes last, versus risking, albeit small, and spending a lot of time with the cupping, the needling, the acupuncture, whatever you want to call it. So to answer your question, get in there, treat it, and then focus on the long-term outcomes. Don't spend a lot of time there. If we don't tell people how to treat, we kind of give our opinions. And when it comes down to busy clinicians, you got to kind of make your choice. If you're seeing 3 patients at a time in some of these clinics, unfortunately, that's kind of what it is in some places. Why don't you do the thing that's safe, effective, quick, and get it, and then move on?
Yeah, well put. I think you just described best recommended practice right there too. So I know you did a scoping review. It's not required to do a risk of bias measure, but what does your gestalt tell you about the quality of the papers that you included in your scoping review?
Yeah, so I mean, that's a good question. I think when I look at the papers we did include, I mean, there's some some high impact journals there, whether it's JOSPIT or PTJ or British Journal of Sports Medicine or JAMA, and then there's some other journals that I've never heard of before, but they met the inclusion criteria and they reported adverse events, so they're in our review. I think that's a tough question to answer, but my gut would tell me that in general, no matter what journal, I think I was surprised to see that there was not more adverse events reported. I think there's probably a there's a reporting bias that might happen. There's a lack of categorization and definition that might limit some researchers. And there's too much confusion on what an adverse event is. So perhaps it's easier to not report it, or, this happens all the time. So we don't need to report it. They're just sore, or yeah, they're a little bruised. We don't need to report it. That's really not an adverse event, depending on what you read. So my gut tells me that they probably occur more often than is reported. If you if you're teaching dry needling continuing education courses and you're doing a paper on it, there could be a little bias there. You might not want to report if it's not required, which I think it should be. If it's not, you might not want to report some of the stuff that can happen.
Well, I mean, I think you said a lot there. We just finished one of my PhD students just finished developing a consent form for dry needling because of the recognition of the challenges with that. And they really did a nice job breaking down the potential risks and how those risks are layered. And you said, that it's difficult to report and record adverse events. 100% agree. As a person who's done a number of trials on manual therapy, I think we reported on it once and we just haven't. I mean, I think it's a difficult capture. I really do. So I completely agree with you on that. So you went to Regis at a time where they had the 85 Bears were involved, right? The 27 Yankees, they were really high quality teaching. And then you decided to do this paper with Steve Karras. Was that a massive letdown or?
Oh man.
Tell me why you got involved with Steve.
Yeah, so Steve's been awesome. He actually advises a lot of our NIOP fellowship students as well as NIOP faculty on research, and is actually my external chair for my dissertation. And so it was just natural that Steve and I worked together on this. Easy to work with. Obviously, he has a lot more experience than I do, submitting articles for publication and doing research. And so he really was the coordinator for this paper. He really, he helped, decide what journal we should submit it to, what was our next choice, talking to the editors and the reviewers and giving me feedback like, yeah, this is a bit wordy. We should take this out, or, you don't need this, or if you can't find a reference for this, you got to take this out. And so he was just really positive force to work with, both on this paper as well as my dissertation. I grew up in Colorado, so I'm a big hunter, and he would always preface a big ask about a paper with something else like, when are you going to send me some elk meat or something like that, and call me Smokey the Bear, or Ted Nugent, which maybe okay in some circles, but just really positive, really fun to work with, knows what he's doing. So no complaints working with Steve.
Well, I appreciate your guys' writing style. I found the paper easy to read, a very quick read, not unnecessary word count. So thanks for that. So Austin, if you were in AOMPT and you were in an elevator full of manual therapists and somebody asked you about your paper, you had to give a 1-minute elevator talk about what you found, what would you say?
Yeah, I would say, I would just start saying, listen, adverse events. There's a lot of attention paid to adverse events with manual therapy to the spine. I think we need to consider the peripheral joints as well. And when you look at the evidence, you're looking at joint mobilization manipulation. There's really not a lot of reported occurrences of adverse events. When you look at the other treatment modalities like dry needling or acupuncture or cupping, there tends to be more reported occurrences of adverse events with those invasive soft tissue techniques. Most of those, if you look at the table, are mild to moderate, but nonetheless, something that we should consider when working clinically or teaching our students. And I would also say that there's not an agreed upon definition or categorization of adverse events yet. And I think Dr. Funabashi is working on that, right? But so just be mindful, and if you're researching it, please report it, and let's see where it takes us.
All right. So you mentioned a lot of interest at the earlier part of this shop talk. What else are you working on now? You working on another paper or another study?
So yeah, I would say I came back from the AOMPT conference very motivated, very excited. I had the opportunity to sit on some 5x5s, and there's actually there was a 5x5 that actually was very similar to my paper. It's Jody Young and Dan Ron and Adam Frisch. They're actually doing a systematic review on the same topic, which I was really excited to hear about that. Steve and I were both there and looked at each other like, oh, this is pretty cool. So I'm looking forward to that paper coming out hopefully soon. I'm looking forward to Dr. Funabashi's Delphi study coming out. But aside from that, I'm trying to get my my dissertation work published that was on vital sign assessments by outpatient orthopedic PTs. Our results pretty much matched what Dr. Severin's paper did. And so I think it's important to try to get that out there. And we did an implementation study of the results from our dissertation, where essentially we said, okay, well, we work in direct access. If it's a direct access patient, whether you're a PT or a chiropractor, you're gonna assess vital signs. And then we had a standard of practice. If it's elevated, you refer, and then you let the primary care physician decide if it's a new diagnosis of hypertension. So we put Dr. Severin's article and my dissertation into practice, and got some really promising results, which I presented that at AOMT. Now we're trying to take a retrospective secondary look at cost savings, early detection of hypertension, which is very challenging. I'm having a hard time wrapping my brain around that one, but that's something that I'm working on. Got a couple case reports I'm working on, one on posterior interosseous nerve entrapment, another one on VBI and direct access. And then, yeah, just I would say a little bit of work going on for the residency outcomes. I think that we have about 10,000 new grads a year. We have about 300 to 500 PTs applying for any residency program. And we have a call for, more experts, more residents, more fellows. I'm not convinced that Dr. Rodecaro's paper is the nail in the coffin for residency. So we just want to take a deeper look at residency outcomes, and we're going to take a deeper look at it from an employer's perspective, because I think oftentimes the employer gets missed when they are the primary reason physical therapists work. If you don't have an employer, unless you're self-employed, you're not working. So we're going to look at that. So we have a lot of patient-reported outcome measures, clinical outcome measures going with that once we start a residency. So I'm pretty excited about that.
Yeah, you got a lot going on. So Austin, if someone wanted to reach out to you or follow you on social media, how would they connect with you?
Sure. So I'm on Instagram at OMPT Guy, the same handle on Twitter, OMPT Guy. I was surprised that handle wasn't taken, so whatever. I'm not sure. I'm the guy, but I'm the guy on that one. And then shelldpt@gmail.com or austin.sheldon@rasmussen.edu. Those are my two emails that I'm checking constantly. And I'm open to discussions, open to feedback, open to collaboration, open to any criticisms or not. Just really excited to get the word out there and try to build on this adverse events work.
I appreciate it. And I appreciate you sharing your work on Shop Talk and just talking to us about it, and keep up the good work. I hope we connect again in the future. Thanks a ton for being on.
All right. Thank you so much, Chad. It was a pleasure and an honor.